I am going to discuss the topic of bronchiectasis, which is an old disease that has made a resurgence. So these are my disclosures. I am principal investigator in a number of trials relevant to bronchiectasis and related infections, and I also have done scientific consulting to set up these trials. So you see my disclosures there. So this is going to be a case-based discussion, just introducing or reintroducing the topic of bronchiectasis to my colleagues here in the Department of Medicine. I want to point out some unique features of this disease, the epidemiology of the disease, how the patient presents and how we evaluate these patients, and then a few words on management, risk stratification, and a lot of talk on unmet needs in this disease because there are many, and that's why we have a few clinical trials underway in bronchiectasis and related infections. So let me just start with the kind of a patient who represents a phenotype that we see in this disease, and I think many of us who see patients who have cough, those of us who do pulmonary, obviously those of us who do primary care. This is a young woman who carried for a number of years a diagnosis of asthma. And she did have wheezing as part of her presentation and on physical exam, but she's quite active. She exercises regularly, and she had been treated for 4 or 5 years as having asthma with short-acting bronchodilators and inhaled corticosteroid and a long-acting bronchodilator. But twice a year, sort of unique for an asthma patient, she had these flares where she would start to cough up sputum, and the sputum would be mucoid or mucopurulent in appearance. And she'd be treated with antibiotics and prednisone. But because the frequency of these exacerbations increased, she ultimately was referred for further evaluation. So I want you to keep this case in mind as I talk through some points here, and then we'll come back to it and to a couple other cases at the end after we finish talking about some of the features of this disease. So, you know, this is a uncommon disease, but it's not an orphan disease. It's actually much more common than probably most of you think. But the unique features of it, besides having a cough, is that the cough is generally productive of mucus. Most patients with bronchiectasis, though not all, have mucus. They have something beyond just a dry cough. One of the rare but sort of heralding features of bronchiectasis is hemoptysis. I mean, hemoptysis tends to get the attention of both the patient and also their physician, and that often leads to making the diagnosis. It probably occurs in about 10% of patients with this disease, but it is something that, again, often brings the patient to the initial attention. And the other unique feature of this, as I pointed out in that patient presentation, is that the patient will have recurrent infectious exacerbations and a frequent need for antibiotics. And again, without further testing, this could just be written off as, you know, recurrent acute bronchitis episodes. But I am trying to lay the groundwork here for you to think about patients you see like this who actually may be bronchiectasis suspects. There is overlap with other pulmonary diseases, so you can have underlying COPD and develop bronchiectasis, and likewise with asthma. I'll explain that a little bit more later. And bronchiectasis can also be the pulmonary manifestation of a systemic disease. And certainly the 3 classic hereditary diseases that cause bronchiectasis, I mean, number 1 is cystic fibrosis. Number 2 is primary ciliary dyskinesia. And number 3, a little more uncommon, is alpha-1 antitrypsin deficiency. So bronchiectasis may be the pulmonary part of those diseases. And likewise, you can see bronchiectasis in patients with autoimmune diseases like inflammatory bowel disease or rheumatoid arthritis or Sjogren's. It also happens in patients with immune deficiency syndromes and in patients with underlying gastrointestinal diseases. So the most recent estimate in terms of epidemiology of this disease is there's somewhere between about 340 and over 500,000 patients in the US with this disease. It is a female predominant disease. About 2/3 of patients with bronchiectasis are women, and about 3/4 of patients are over the age of 65, although this does span the lifespan. It's definitely been increasing in incidence and prevalence, and so that's part of the reason to, alert to this diagnosis. A study that was done several years ago now through the NIH showed about a 9% increase per year in the early part of since 2000. And just to put it in perspective, right, we're talking about here, the bulk of this talk is going to be about bronchiectasis unrelated to cystic fibrosis. So again, probably about 500,000 patients with this disease in the US, compared to only really about 35,000 US patients with CF bronchiectasis. So non-CF bronchiectasis, if you will, is a lot more common than a disease that we often hear a lot about, cystic fibrosis. And also, again, to put it in perspective, for every one patient diagnosed with bronchiectasis, there's about 20 patients with COPD. So obviously it's a lot less common than asthma or COPD, although it can be a complication of those diseases. And this is the classic explanation for the pathophysiology of bronchiectasis that was published by Peter Cohen in the 1980s. And the thinking here is that there's an initial insult to the lungs, and that can be an infection, that could be an aspiration episode, that could be any inhalation injury, and that insult sets up a neutrophilic and occasionally eosinophilic inflammatory response, which results in airway inflammation, airway damage, airway distortion. Because of the airway distortion, mucus pools in those abnormally dilated airways, and that mucus is then ripe for bacterial colonization and sort of stasis of the mucus. And our thinking is that this is a vicious cycle. The initial insult sets it off, but then the inflammation results in this damage that results in the retention of mucus, and that mucus is the breeding ground for the bacteria, and then this goes in circles and it continues, and you wind up starting out with a nice pristine airway in that upper image there, and you ultimately wind up with these airways that are dilated and packed with mucus and often infected with bacteria. So every Grand Rounds needs a slide like this, I get. This displays on a more micro level, if you will, what goes on in the airway in patients with bronchiectasis. And obviously it's a busy slide, but just to point out, you have your mucosal lining cells that have cilia, and then there's a mucus layer in the airway in patients with normal airways. And what happens in this disease is, again, this vicious cycle of inflammation. A lot of inflammatory markers arrive into the airway. Bacteria follow that, and then biofilms form, and the bacteria kind of get caught or hide in these biofilms and become much more difficult to kill. So again, this is kind of the vicious cycle writ large, explaining more of the details of the inflammatory response. And again, we think about 2/3 of patients with this disease have primarily neutrophilic inflammation and a lot of neutrophil elastase and different inflammatory cells and inflammatory action going on. But probably about 1/3, 20% to 1/3 of patients also or either have eosinophilic inflammation in their airways. And this is important because now we're trying to target some of these, with biomarkers and learning more about on the micro level here, coming up with different therapies beyond just plain old antibiotics. So this is my visual that I use with patients to help them understand the dilation of their airways, the resultant mucus plugging, and again, the fertile ground for recurrent infections. So how do we confirm this diagnosis of bronchiectasis? It's basically the clinical scenario that I just outlined and the presence of bronchiectatic airways on imaging. And we like other tests. We like pulmonary function tests. We obviously find that respiratory cultures are very important. There's some other blood work that we like to look at. But the most important thing to confirm this diagnosis is a high resolution CT scan. And let me just show you a few images here. This is a close up of dilated airways, and the way we can confirm the presence of bronchiectasis is to see that the diameter of the airway is larger than the diameter of the adjacent blood vessel. So this is a real nice example in this left-hand panel of seeing really dilated airways with thickened walls. And you can see where that would result in what you see on the right-hand side, which is actual mucus plugging in these dilated airways. And in this patient, a little cavity as well. But the mucus just gets intussuscipated into those dilated airways, and then infections result. And patients usually cough up quite a bit of sputum. Now, there's some other features that we see besides what I just showed you in terms of airway dilation. It's also the enlargement of airways close out to the periphery of the lung. And in that upper CT panel there, you can see some mucus again in those dilated airways. And the lower panel just shows a nice example of what we call tram lines, which again is just seeing the outline of the thickened walled airways on both the scalp film here and on this lower left-hand panel. And some patients take this to the max here, right? And cough up tons of purulent sputum and just have their airways just totally plugged. I mean, these examples are amazing. Still struggling to take care of this patient because his airways, you can see the dilation of the airways in this upper panel. But in the scout film view, it's like fingers of mucus, thicker than fingers, really stuck in the proximal airways of this patient. And then some of the airways are just dilated without mucus. So, some patients are produce so much mucus, and this is often seen in allergic bronchopulmonary aspergillosis, but these finger and glove mucus plugs, you can imagine how devastatingly hard it is to get that mucus out of patients by just coughing. And then finally, another type of radiographic feature we see in bronchiectasis is what our radiology colleagues typically call tree and bud. And I finally found a nice tree and bud little picture here that goes along with what they correlate with that on the CT findings. So again, mucus plugged in the small airways, like hanging right off the branch of the airway is what accounts for the tree and bud description. Patients like this often don't cough up a lot of sputum. They're more dry or have more mucoid rather than mucopurulent sputum. But this is a common phrase that the radiologists use to describe this more nodular type of bronchiectasis, where the mucus is really impacted in the very small airways out towards the periphery of the lung. I put these other images in here to describe a certain phenotype of patients that we see with this tree and bud type nodular bronchiectasis, and that's the tall, thin, small-waisted female who is prone to this type of bronchiectasis, and this is often goes along with having non-tuberculous mycobacterial infection. So that's a quick look through the imaging that confirms the diagnosis of bronchiectasis, and the imaging of the patient that's sort of susceptible to probably at least one phenotype that's susceptible to bronchiectasis. Let me move on to how we risk stratify these patients and prognosticate about how they're going to do. I mean, the vast majority of patients with bronchiectasis do very well. And it's obviously important to diagnose them in a timely fashion to help them, to treat them, which I'll get into shortly. But most patients do well. But the ones that really have severe disease, you can see the hallmarks of more severe disease. So older patients, patients with the worst lung function, FEV1 less than 30%, patients who have bronchiectasis, so the anatomic diagnosis of bronchiectasis, but are infected with Pseudomonas. I mean, Pseudomonas is definitely a bad actor in patients with this disease. The extent of the disease on the CT, so 3 or more lobes involved. Thinner patients, again, not a big surprise, I would say, but patients with lower BMIs have a worse prognosis. And the more exacerbations and the more hospitalizations the patient has, the worse the prognosis as well. So we have these scores that we use, one called the BSI and one called the FACID, which help to predict. But again, mortality is uncommon in this disease. Generally, it's the comorbidities that are present in some of these patients that are the lethal factors. But these features really are what get our attention when we're seeing these patients with bronchiectasis. So this is a busy slide, quote unquote, but I just wanted to make the point that this is a very heterogeneous disease. I already said that, right? That there's a number of reasons why patients get bronchiectasis. And just to reiterate, right, there's the genetic causes, but those are relatively uncommon. There's the connective tissue disease, autoimmune diseases, like RA and Sjogren's that, again, can predispose to bronchiectasis. The sort of thing we often wind up attributing this to is prior infection. And, we used to say like pertussis in childhood, but, who knows if they really had pertussis in childhood. Any virus or any prior infection, especially patients who had tuberculosis that left scarring, that is often an underlying cause of the bronchiectatic disease. There's also a subset of patients who have what we would consider focal bronchiectasis, so confined to one lobe or relatively small area of the lung, and that actually can be related to the chronic presence of a foreign body or post-surgical displacement of the lung. Some other things to think about, I mentioned before, immune deficient patients are at risk for bronchiectasis. Patients who chronically aspirate or who have inhalation injuries can also develop this disease. There is an association with other airway diseases. I mentioned COPD and asthma, but there are rare patients who have unusual causes like tracheobronchiomegaly, who develop bronchiectasis. And but about, even with due diligence and being very thorough about evaluating these patients, still about a third of patients wind up being considered to have idiopathic disease. So, turning to, we diagnose the patient. Hopefully there hasn't been a long delay in making that diagnosis. And then we take a systematic way to evaluate the patient for one of these underlying disorders. So we generally check their immunoglobulin levels. We at least assess whether they're at risk for genetic disorders, and I'm going to make a couple more comments about these later. We check the immunodeficiency. We look for autoimmune disorders. Of course, our colleagues in rheumatology can remind us that the lung disease of RA may show up before the joint disease. So it's worth considering the possibility of Sjogren's or RA, even if the other manifestations are not there. And again, a workup for swallowing disorder, esophageal dysfunction that might be soiling the lungs and causing bronchiectasis is in order if the patient has those kind of symptoms. We have some really well-developed guidelines in this disease that actually give us good advice about how to do the evaluation of the patient and also to treat the patient. So put these in here. We're actually working on some US specific or North American specific guidelines right now, but the most recent one was published by the British Thoracic Society. There's also a recent actually adolescent and childhood bronchiectasis guideline that's come out in the European Respiratory Journal in addition to the adult one from 2017. All right, I'm going to turn to sort of an overview of how we treat these patients and how we convince the patients that they need this treatment. But so I start with educating the patient about the disease. I mean, the word bronchiectasis doesn't really roll off the tongue of most patients or even most physicians. It's kind of a joke in our place when we have these research people come to see us for our studies and they can't pronounce the word bronchiectasis. We're a little skeptical of their research offerings. So again, it's a tough diagnosis. There's not a ton of patients or that patients can talk to each other about this. I mean, it's something that spending a fair amount of time educating the patient and showing them those visuals and showing them their CT images is quite important. I also really like to understand the impact of the disease on the patients, like how symptomatic are they day to day and how many exacerbations are they having in order to tailor the treatment approach. It is very important, as I already alluded to understand the extent of the disease, to risk stratify the patient based on the things that I mentioned previously, especially the extent of disease on CT and how impaired they are based on their pulmonary function. And then the last thing is I really need to know what bacteria are down in those lungs in order to do a good job treating these patients. And there's sort of two parts to this, right? There's the day-to-day treatments that the patients need, and those are really designed to reduce the number of exacerbations, control the symptoms, improve the quality of life, preserve the lung function, and make them healthy, you know, and live longer. And then we do deal with the exacerbations, and we have strategies for that as well. So going back to the vicious cycle, vicious vortex idea of the one inflammatory process leading to damage and infection, we really try to target each aspect of that cycle in order to reduce the burden of disease for the patients. So if there's a treatable underlying disease, we'll treat that. But then in general, the next step up for the patient is to engage them in airway clearance therapies, and those can be mechanical or pharmacologic. Next step, if the patient doesn't get symptom benefit or not enough benefit from airway clearance, we'll go to anti-inflammatory therapies. And finally, for patients who are really frequent exacerbators or heavily burdened by day-to-day symptoms, we will use a maintenance antibiotic strategy. We treat exacerbations based on what the organism is, and sometimes we have to resort to IV treatments and generally done at home if the patient has an organism that's not susceptible to oral antibiotics. And then the other interesting thing in the world of bronchiectasis, and this applies in CF bronchiectasis as well, is that there's a small amount of data suggesting that a very aggressive antibiotic strategy when you first identify particularly Pseudomonas in the patient may be worth trying. And our European friends call it eradication. I call it like pseudo eradication because it's very hard to get rid of these organisms and they never come back. But that is a strategy that's becoming more widely adopted if you know the patient sort of is newly infected with a particular organism, mainly Pseudomonas. So I'm going to talk briefly about one of my favorite topics, airway clearance. And sort of been a dying art in our U.S. world. I mean, if you go to any bronchiectasis center in the UK, they have a physiotherapist there at the ready to teach the patient these airway clearance modalities. In the US, unfortunately, we don't have that cadre of people, even among our respiratory therapists. But in our center, where we see a lot of patients with this disease, we put a lot of emphasis on learning airway clearance techniques. And the idea is that this helps clear the sputum, reduce the cough, reduce the dyspnea, and hopefully, although the evidence is not that strong, that it actually interrupts the vicious cycle of disease. So, traditionally we taught patients the postural drainage and cupping and clapping. This has kind of gone by the wayside for a couple of reasons. One is obviously it takes a second person in addition to the patient to do this kind of cupping and clapping, traditional chest physiotherapy. It's also sometimes uncomfortable for the patient, and it can exacerbate reflux, right? If you put the patient head down, which may actually make their lung disease worse, right? So we've gone to more techniques that patients can do themselves. And I mean, I could do a whole hour on all these techniques and show you videos and that kind of thing. But basically, we give the patient options. We try to train him in huff coughing and helping to bring the sputum up and out. The evidence, like I said, is not fantastic for this. And the uptake by the patient really depends on us to educate the patient adequately and sort of engage them in the importance of this therapy. We do have some devices that are easy for the patient to use that have a flutter and positive expiratory pressure component to it that helps them with mucus clearance. And we even have these high frequency chest wall oscillating vests, which again, shake the mucus, if you will, from externally to help with mucus clearance. Again, picking the right airway clearance therapy for the patient is really a shared decision-making with the patient. We will often start with those mechanical things and then add a pharmacologic agent for mucus clearance. And although a paucity of evidence, the thing that we use most commonly nowadays is hypertonic saline, 3 to 7% saline. Again, I put the reference here. It's 32 patients, not fantastic science, but many patients do benefit from the use of hypertonic saline as an adjunct for airway clearance. The thing about this, though, it takes a lot of time on the patient's part, and there's so many different gadgets, and they have to be cleaned and sterilized, and this takes effort on the patient's part, and it's on us to educate the patient. There's a really great website called the Bronchiectasis Toolbox, which has videos, and I often refer patients to that to help them with all the work that goes along with doing these techniques. The other thing that can be helpful for these patients is pulmonary rehabilitation. I've shown this picture before. One of my patients who runs with her supplemental oxygen and her oximeter attached to herself to monitor herself when she used to run outdoors. Now it's more on the treadmill, but there is a role for this, of course, in almost any lung disease, but a little bit of data to support using it in this disease. Let me turn now to another strategy that we sometimes take in patients with bronchiectasis, and that's the use of macrolides as a long-term anti-inflammatory treatment, actually more than antibiotic treatment, to reduce exacerbations. And here we do have data, 3 pivotal studies, if you will, that showed that long-term use of macrolide, primarily azithromycin, had a positive effect on patients' symptoms and on reducing exacerbations. I mean, the mechanism of action is thought to be anti-inflammatory rather than infectious, because it does help patients with Pseudomonas, for example, that azithromycin wouldn't have an antibiotic effect for. So this is an option for some patients. The problem is, of course, not everybody can tolerate taking a long-term macrolide, and there's drug-drug interactions and QT prolongation, et cetera, that you have to be cautious about. The other anti-inflammatory therapy, of course, is steroids. And we really actually try to avoid using steroids, either inhaled or oral, in patients with bronchiectasis, because there's actually good evidence that they actually promote particularly non-tuberculous mycobacterial, but other infections as well. So kind of that knee-jerk, Advair for anybody with airways disease, you really have to be cautious. And we actually try to get people off the steroid component of their inhaled therapy if possible when they have bronchiectasis. I do want to point out the common pathogens. I've already alluded to Pseudomonas. It's about a third of patients in our US registry that have Pseudomonas chronically in their airways. We see in other parts of the world, they see more Haemophilus. We see that less frequently. About 10% of patients in our US registry are chronically infected with staph. And then the big thing, and again, topic of another talk, is how common non-tuberculous mycobacterial infections are in our United States patients, and in Canada as well. A lot less common in some other parts of the world, and require very specific therapies if the patient needs antibiotics. So again, in this stepwise approach to treating the patient, again, treat the underlying disease, do airway clearance, think about a macrolide if the patient's appropriate for it. If that fails to reduce their exacerbations or improve their symptoms, then we'll go with inhaled antibiotics. And again, there's a lot of literature on this. Most of it most of the studies have been done in patients with chronic Pseudomonas infections. There's lots of questions and not a lot of good answers, but we do resort to this sometimes for patients with mainly gram-negative infections who are frequently exacerbating or very symptomatic. This is sort of my sad list of studies that I've been involved in the last 25 years in bronchiectasis. A lot of good effort went into looking at a lot of different inhaled antibiotic classes, primarily aminoglycosides, but others. And not a lot of good positive studies have come out of this yet. So we're still struggling to identify the right patient and the right format and dosing of inhaled antibiotics. Right now, probably the most positive data we have, but not enough to get any of these drugs FDA approved, is an inhaled aztreonam, inhaled tobramycin, of which there's a nebulized form and a dry powder form, and a study that we have been involved in with inhaled colistin that we don't yet have the data on, although we sometimes prescribe it off-label. So basically, when I'm up to the level of giving the patient, highest level therapy, if you will, I choose a macrolide if the patient can tolerate it. If there's no contraindication, like the things I mentioned there, we go to an inhaled antibiotic if the macrolides are either not helpful or not appropriate for the patient. And so just to summarize the things that work in bronchiectasis, really airway clearance, macrolides for certain patients, and inhaled antibiotics. And the things that we should avoid using are routine inhaled corticosteroids, or obviously oral steroids. Routine untargeted oral antibiotics are not a good idea, and we don't want to use macrolide monotherapy if the patient is infected with mycobacterial organisms. Occasionally, we resort to surgery. This is a nice left lower lobe from a patient. You can see how dilated those airways are in this fresh specimen right after the lobe was excised. And so for some patients who have relatively focal disease, this is an option. lung transplantation, it sometimes comes to that, and patients who are transplanted for bronchiectasis generally have about the same outcomes as patients with cystic fibrosis disease. And sometimes we do recommend anti-reflux or anti-aspiration procedures, more correctly, in patients that appears to be the cause of their bronchiectasis. Some new things that are in the pipeline that I alluded to before, trying to be more targeting the pathology more than just the complication of the bacteria. And the thing that's the most exciting right now is to target the neutrophilic inflammation. And there's several drugs in the pipeline that actually affect the neutrophil elastase levels. And a phase 2 study has been completed, and a phase 3 is underway, and we're enrolling in that study. So we were part of this phase 2 trial, the brensocatib, which is a neutrophil elastase inhibitor that did show promise in this phase 2 trial that was published in the New England Journal, and then we're now enrolling in a phase 3 trial for this. All right, well, just to sum up here, I'm going to go back to the case that I mentioned to you before, young woman with asthma, but the unique feature was these frequent, seemingly bacterial exacerbations. Even though she was active and exercised, she had quite low lung function. And gosh, when imaging was finally done, she had quite severe bronchiectasis. You can see this nodular and the cystic bronchiectasis here on these CT panels. So, she has 5-lobe disease. The diagnosis was unfortunately delayed. Imaging hadn't been done because she was thought to be kind of a routine asthmatic. Cultures hadn't been done because who does cultures except in pulmonary world on sputum? And ultimately, we treated her very aggressively and in the manner that I just discussed. Here's another case, and again, this is a learning lesson for all of us, right? This is again a middle-aged female with chronic cough and sputum production, and unfortunately, a lot of these patients get labeled as either asthma or COPD, and it's very difficult to call somebody as COPD if they've never smoked or not been around exposures to wood-burning fires or other causes, rare causes of COPD. And again, this is another patient that, because the imaging was delayed and culturing wasn't done, her diagnosis was delayed, but she did have significant bronchiectasis and was infected with both Pseudomonas and mycobacterial organism. So to sum up, I approach these patients with the guidelines that I referred to earlier in mind, and then I tailor the evaluation of the patient to their symptoms, their age, their history, whether they have comorbidities. So as a basic evaluation, once we have the CT scan, we definitely want to look at their CBC, their immunoglobulin levels, and then we think about doing other testing based on their comorbidities and their symptoms. I do want to say a word here about the 3 big genetic causes of bronchiectasis. I'd really be remiss if I didn't, we should again have a whole talk on cystic fibrosis, because although there's only about 35,000 patients in the US, the scope of research and evolution of treatments in the last 10 years has just been completely disease changing. So it is very important, and I'm speaking to my primary care med peds and med colleagues here, especially to think about CF in patients who present, as I mentioned earlier. Obviously, many patients with classic CF also have sinus disease. The males are infertile. They have pancreas disease. But there are a cadre of patients who do have CF, and because we now have genetic testing, we identify them later in life, and they don't necessarily have all those other extra pulmonary involvements. So we still do sweat testing for CF to look at the sweat chloride levels, but the genetic profiles, you can go from a small profile to a bigger one, are commercially available. And because it's so important to confirm this genetically, because there are specific modulator therapies in CF. The second disease, is primary ciliary dyskinesia. And actually, I have a number of patients with this. Some of these patients have situs inversus, but many don't. And probably from your med school days, you remember those little pictures of the dying arms and the little waving cilia. It turns out that that's not really the best way to diagnose PCD. And we actually do some more of like a different type of electron microscopy nowadays for that, measuring exhaled nitric oxide. But there are genetic tests now for PCD. They're not as refined as in CF, but we should suspect PCD in patients who have obviously symptoms since childhood, if they had neonatal respiratory distress. Many patients with PCD, or most, have had chronic ear infections. Some have hearing loss, and most have sinusitis, and they're all infertile. So if you have a patient with a chronic cough who has some of those other extra pulmonary signs and symptoms, you should really think about this. And it's kind of exciting in PCD because it was a super orphan disease, and now a lot of genetic understanding is coming to the fore, and some targeted therapies will be in the pipeline here soon. And lastly, alpha-1 antitrypsin deficiency. Again, people commonly think of this as causing emphysema or liver disease, but it can cause bronchiectasis, and we do obviously have a replacement therapy for that. So my take-home messages to my primary care colleagues: if you see a patient with chronic cough who just, you're prescribing azithromycin 2 or 3 times a year, or amoxicillin, think about this, right? Think about the possibility that they may have more than just a bronchitis or sinus disease, and, get an x-ray. A regular x-ray is not necessarily diagnostic for bronchiectasis, but you do have to, I'm actually interested in doing a survey from our Cerner records to see like how many patients get 3 or more rounds of antibiotics and what ultimately happens to them in primary care. So a thought for a study. Our allergy colleagues obviously see asthmatics, patients with increased IgE, eosinophilia, allergic bronchopulmonary aspergillosis. Those things are associated with bronchiectasis. And so you need imaging, lab work, and sputum cultures in these kind of patients. Our GI colleagues, with patients with inflammatory bowel disease who have a cough really should be looked at for having lung bronchiectasis, and patients who aspirate either because they don't swallow well or because they have esophageal disease or a bad hiatal hernia with the intrathoracic stomach. Those are the kind of patients that we should look at for bronchiectasis. I already mentioned rheumatologic and hematologic predispositions for developing bronchiectasis. And finally, the patients with bronchiectasis, there's a number of support groups and patient organizations that really have helped us as physicians to understand patient priorities. This was a group that got together and was published in Chest in 2018. And of course, patients want, they don't want to spend 5 years coughing and not getting the diagnosis. They want us physicians to be educated about the disease. Once they're diagnosed and we tell them they have to do, 3 hours of airway clearance and 2 inhaled antibiotics and whatnot, they want us to get it together and have a better and a less burdensome amount of therapies. And of course, they want better outcomes. I've mentioned CF. Again, this is the patients that I take care of are primarily don't have cystic fibrosis, but I just want to leave you with the message that, CF is out there, and we have such good therapies for certain genetic CFTR abnormalities that we really don't want to miss these patients in their younger years. And there's lots of unknowns that we deal with in this disease still. Can we really eradicate bacteria? We have a relatively limited understanding about, from a translational and basic point of view, about the interaction between the host and the infections in these patients. And we're really working hard to understand all of those things a little bit better. I just put this out here. These are the trials that we've been involved with, and the first one is currently enrolling here. We haven't had a number of patients go through this trial and the phase 2 version of it. We just completed our enrollment in this inhaled colistin trial, and results are pending. And we have another neutrophil elastase inhibitor trial that's about to open, as well as our involvement in the US bronchiectasis registry. So we're trying to recruit patients for these trials, particularly because the natural history is not that well known. The treatment approaches are individualized, and we've done a lot of work in this disease, but we still haven't hit the holy grail. And so getting patients involved in trials has been helpful. And I would just conclude by saying, I hope I put this back on your radar screen. It was actually Laennec that initially described bronchiectasis besides cirrhosis. He didn't have a CT scan back then to prove it, but he had clinical data and autopsies that actually was the first description of this disease. The patients are very heterogeneous. You just have to think about it in order to find the patients with it. It's actually fairly easy to make the diagnosis because the sine qua non is CT scanning, and the evaluation and the treatment of the patient is guideline based but individualized. And we do have some new therapeutics and new basic and translational research that's going to be very helpful in this disease. So thanks for your attention, and I'm happy to take some questions.